I should say, rather use this platform to give a special thanks to Dr. Gyan, who initiated and helped. Dr. Gyan, thanks a lot for the endoscopic version of thyroidectomy when we started. And subsequently, it's now many years, almost 10 years, we have been doing endoscopic, both BABA and vestibular approach. From November last year, now we have robot in the Department of Surgery. So we stepped up, and as we are all as surgeons, we want to take every bite from new technology and all. So we started doing robotic. After having an experience from the BABA, so it was not a very big challenge to except for learning the technical part of how to use the robot. I present here the details of a case. She is young, 38 years, who had already a major surgery, dual valve replacement in 2024 for the RHD, and she was on anticoagulants. And during one of the CTs, follow-up CTs, they instantly found a nodule or some lesion in the thyroid. That's how she was further investigated and found that she had an oval-shaped hypoechoic nodule, 27, 13, 16 millimeter posterior aspect of the upper pole. As it is, she already had a major surgery and all. She didn't want further surgeries on the neck. She was trying to avoid it. And we did counsel her, and finally she agreed for this approach. So she had lesion only on one side. Since she was already a high-risk case, so we decided to have a total thyroidectomy at the beginning itself. We took her consent, and this is how we usually place the patients. That's a position of the patient. Sorry for too many markings, but these are the basic markings that are used for the BABA approach. And we don't make dissection under open vision. That is the rabbit, which is another procedure. And one more technique is the posterior auricular. And this is the one that we use extra port as the laparoscopic port, in addition to the 4 robotic ports that help us to create the whole dissection and the space under vision without making any trocar dissection and blunt dissection. So this is the first port, anterior axillary line, and we make a small straight artery dissection into the space. And then we place the first robotic port, insufflate it, and then we have a small 5 mm laparoscopic port just behind the anterior axillary line below the first robotic port. That helps us to create a pocket of air and small dissection under direct vision. And then as we go on, we place the second port. Our scope gets transferred to the second robotic port, and we make a straight entry into from the first port for the dissection under direct vision. I'll show the video how it happens. So all the dissection is finally done under vision. This is placement of the third robotic port. And this is final view, how the trocars look from outside. This view is from other patient that should give an overview of the placement of trocars. And then the robot docking takes place. So this is the initial view of the small pocket that we create. And we use energy device, either harmonic or ligashore. And the second robotic port under vision, and then further down to the opposite side, and all rest ports are placed under direct vision. So we don't target usually, because the all the ports are in a semicircular type of fashion. So the robot doesn't take it. So we do it without just positioning of the camera, which is in the third port. This is opening of the first the midline and then the right lobe lateral dissection, inferior polar dissection. We use the scissors and fenestrated, and plus a progress for lifting and having the retraction. This is the inferior vessel and taking utmost care to preserve the parathyroid at the same time. And with the bipolar, we take down the vessels. We can burn them with the bipolar and cut them with the scissors and preserve the parathyroid. Going to the superior pole, since it's for malignancy, we have to be careful that you take the whole gland complete without leaving any tissue behind. So this is the superior polar dissection and dissecting it. That's how the right lobe was dissected, and now we take it off from the trachea with sharp dissection using scissors and the energy source along with it. And you can see clearly the right laryngeal nerve and the parathyroid, it's preserved on the right side. And now we dissect. There was a small pyramidal extension that was completely detached. This is complete separation from the trachea. And now we move, we don't divide it. We keep the whole gland in total. And this helps in retraction actually. Move to the opposite side and the inferior pole of the left gland or the lobe. This is the parathyroid and the vessels that are preserved. The big difference that we found from endoscopic versus the robotic, the vision, the magnification, it goes sharply 12 times. And the magnification of seeing the vessels and parathyroid is actually an experience in itself. It helps a lot. For the completion, we further take the left lobe away, going up to the superior pole, completing the lateral dissection there. And this is the recurrent nerve of the opposite side and parathyroid, preserving it and lifting the whole gland away. The superior polar vessels. So we keep away from it as close to superior pole as possible, protecting the nerve parathyroid. We have made no attempt actually to see the superior nerve here. This is the completion of the thyroidectomy. The glove bag we use for this, it's quite soft and manageable. And the retrieval, we close the midline and place a drain for completion of the procedure. This is the specimen, and the histopath confirmed it. There was no lymphovascular invasion, the capsule was intact, and opposite lobe had no tumor. Post-operatively, she was quite comfortable, and calcium levels were 8.5 milligram per deciliter, no voice changes. And since she had to be put back on the anticoagulants, so we retained the drain for a little extra time. And You can see the movements of this patient's neck. And she is being followed now. Thyroid scan has been done and already ablated. It was less than 1% of the residue that has been ablated. This is the first case here, demonstrable. Yeah, I just finished. The outcome of this patient, follow-up. And there's one more lady who, young girl, very thin. We were a little skeptical about what will happen to the flap raising and all. Hardly any fat to her, but it worked well. So I'll not go in discussion now. Time's already up. There is meta-analysis where it's agreeable now that there are better outcomes with use of robot as compared to endoscopic. But long-term results are almost the same then, but visibility of the nerve and the parathyroid makes the difference actually. So the take-home message is it's a safe procedure. With improved precision, we can preserve the parathyroid and see the nerve, and therefore the complications are maintained. There's increased dexterity, the suturing and maneuverability inside is possible. We can use this procedure for little larger size thyroids also. And of course, with better cosmetic satisfaction and early recovery. Thank you so much.